All right. We're going to talk about chapter 26. We're talking about management of different patients here with arterial and vascular disorders, and just in general, talk about peripheral kind of arterial disease and peripheral vascular disease. So, again, anatomy, physiology. You guys should know this by now, but our heart does the pumping. We have a network of blood vessels that are called arteries, and a network of blood vessels called venous. And arteries are leaving the heart. Arteries always go away from the heart, meet up in a small connection exchange vessel called a capillary, and then the other side is the vein that returns the blood to the heart. So with vascular stuff, usually their health history is going to include some kind of pain of their extremities and other precipitating factors like exercise, temperature changes, that sort of stuff. We're looking for what's called intermittent claudication. So intermittent claudication, that's a word you want to know. Intermittent claudication is saying that there's microclots basically forming. This blood clots form and somewhat dissolve, and sometimes kind of intermittently, kind of for a time will block blood flow, and then they kind of dissolve and release, and that's intermittent claudication. Physical assessment, we'd be looking for like changes in skin color, changes in issues with wound development. Do they have a accessible, palpable pulse? And then there's other imaging we would be doing, CT scans, angiographies, Doppler ultrasound. A Doppler ultrasound is just a small ultrasound device that really just bounces the signal off the artery and reads a pulse, and it'll just sound like a whooshing sound. We could go full on MRI, MRAs with contrast and really get detailed. So arterial disorders, any disorders with involving the artery, are the same problem as you would have with coronary artery disease, and the risk factors are exactly the same for development of coronary artery disease. So the same modifiable versus non-modifiable risk factors you'd see in that, it's all related to the atherosclerosis. So family history of arterial disease, diabetes, hypertension, atherosclerosis, and arteriosclerosis development all lead to potential, especially atherosclerosis, potential plaque buildup in arteries in the peripheral system, leading to skin issues, fatigue, loss of pulse, loss of feeling, intermittent claudication, those kind of things. Same risk factors as coronary artery disease. Management is, again, they can do procedures to kind of like a coronary, like a cath, like a PCI, a percutaneous coronary intervention. They can do intervention to try and open up blood flow and get an idea of that. We can do imaging to see if the blood flow through the arteries is effective or if it's blocked off. And hopefully the goal is for us is to retain circulation, because we need to have a circulation to, our extremities, promote vasodilation, medications that promote that, try to help relieve the pain, and then overall maintain the tissue integrity, make sure the tissue has blood flow to get adequate nutrients. So peripheral artery occlusive disease, usually known as just PAD. PAD is peripheral artery disease, is usually what people call it. This is more commonly found in the lower extremities. The hallmark manifestation for most of these, for any arterial disease, is pretty much going to be intermittent claudication. Plus, you would kind of add on the 5 Ps. So, what are the 5 Ps? So, the 5 Ps of PAD, which is kind of fun to say, the 5 Ps of PAD, these are good, need to know. So, if you're thinking about peripheral arterial disease and you're thinking about manifestations of PAD, here's the 5 Ps. Pain, obviously pain. When blood flow is not getting to tissue and cells die, that equals pain. So it's pain is one of the P's, usually ischemic pain. Pallor, so lack of color, normal ethnic color, whatever, it's pale. Paresthesia is the third P. Paresthesia is the numbness, tingling sensation. Pulselessness, so I have no pulse, distal to the location of this. And then paralysis, full on, no function to an extremity because of no blood flow. And skin changes are pretty common with this, is all under common manifestation. So how do we manage PAD? Well, We can do medications like statins, which are trying to lower cholesterol. We can do antiplatelet drugs like Plavix, Eliquis, aspirin. We can put stents if they need to surgically. We can also surgically remove, do an endarterectomy. We can remove the plaque buildup wherever it is and fix the artery that way. We can also, there also is bypass surgery for peripheral arterial disease as well. We can do a graft with a vein and go around the blockage if we need to restore blood flow. Nursing wise, we want to think about always assessing the extremities that are affected. So checking for pulses is a big thing. Doppler assessment, that small ultrasound, any color or temperature changes. Is cap refill intact? Is there sensory perception and motor function intact? That would be the paresthesia paralysis. So, what do we recommend? We tell people with arterial disease, especially the periphery, we say, don't cross your legs if you can avoid it. After a procedure that you've had done to your legs, edema and swelling are going to be pretty normal. Upper extremities, keep them at heart level. Excess blood pressure on non-surgical arm if we did surgery there. Some other arterial changes that we want to note is an aneurysm. You need to be able to define an aneurysm. Most of you know what an aneurysm is, but the simple definition is it is a dilation around a point of a wall. So it's a weakened wall of an artery, and it usually dilates in a specific way. So these are different types of aneurysms. They have, the saccular, fusiform, false, dissecting. That doesn't really matter as long as you have a general idea what aneurysm is. An aneurysm is not necessarily bleeding yet. An aneurysm is a weakening of the arterial wall, and it's usually going to be related to atherosclerosis and increased pressure in the artery. So your biggest risk factor for aneurysm development, any guesses? Ding, ding, ding. Hypertension. Your biggest risk for aneurysm development is going to be hypertension always, because it's about blood vessel damage. The higher the pressure, the more the artery gets kind of pounded and it's going to get damaged. So atherosclerosis and arteriosclerosis are a long combination with hypertension are your biggest risk factors for aneurysm development. Manifestations or symptoms associated with aneurysms depend on where it's at. Pain is usually the predominant symptom, but you could have some respiratory pressure on the lungs, so cough, difficulty swallowing if it's an artery in your neck, like the carotid artery has an aneurysm, which is more rare, but it could compress veins and other things, tissues around it. So, I mean, the biggest risk factor for development is definitely hypertension, atherosclerosis. One of the most common ones we talk about is what's called a AAA. And the AAA is the abdominal aortic aneurysm, AAA. So the most common cause is still atherosclerosis. If untreated, this aneurysm could weaken the wall enough to rupture and then bleed to death in minutes, not days or hours, minutes. They would bleed to death. So some of the manifestations with the AAAs, I feel my heart beating in my abdomen, like they feel the pulse down there. There's actual a palpable mass, and they may have pain associated with whatever it's pushing on. And you can actually see this mass here. That's more rare, but that's a possibility for sure. And so, what do we want to do for aneurysms? Well, again, the biggest scary thing about an aneurysm is rupture. So, a lot of times, they could potentially need surgical intervention. Before surgery, you want to anticipate the possibility of a rupture. The biggest risk is that aneurysm wall finally weakening enough to rupture, and when it's high pressure, it's just going to start spurting out. It's going to start bleeding very fast. So we want to really keep blood pressure controlled with an aneurysm, because that's the main culprit. We can't have pressure too high. So for us and management, blood pressure control, and then probably going to have to go to surgery and really, 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 really monitor for bleeding. If someone has a AAA and they complain of like sudden lower chest, abdominal pain, typically one of the hallmark signs of a ruptured or hemorrhagic aneurysm of the aorta is this like mid spinal back pain that's very sharp, and all of a sudden, if someone had a known AAA and they had sharp back pain, I'm telling you this for a reason, guys. I need to know sharp back pain on the midline of their spine, then that would be an indication of a ruptured aneurysm. Dissecting aorta is another type, like basically type of aneurysm that manifests itself in the aortic arch. Usually, again, hypertension, trauma, cocaine use, usually associated with pain. One thing that I'll highlight from this chapter is Raynaud's phenomenon, also called Raynaud's disease. Raynaud's phenomenon is this intermittent vasoconstriction. Raynaud's phenomenon is associated with peripheral arterial disease. It's a possibility. So if someone has Raynaud's, they have a degree of PAD in some form or fashion. But Raynaud's phenomenon or disease is triggered more with emotional responses and triggered with like going out in the cold. And the manifestations are that people are going to have like this abnormal pallor of their distal fingertips or distal toes. It's going to be always distal, where the smallest blood vessels are. And then it could lead into cyanosis and that rhubarb, that redness that happens like this. So they want to control blood pressure and avoid like triggering stimuli. So for Raynaud's, it's like avoid the cold, avoid stress factors to try and alleviate the outburst or like the exacerbation of Raynaud's. So arterial embolism and thrombosis. So we can get a thrombus formation and we can get an embolus that moves around the artery. Usually arrives from the heart if they're going to arise from anywhere. We can treat this with blood thinners and manage any bleeding or bed rest. On the venous side, the venous thrombolism, venous thromboembolism or VTEs is sometimes called VTEs, venous thromboembolism. Basically, is the more common. This is where you hear the conversation DVT and a pulmonary embolism. Basically, the risk factor here is still kind of high blood pressure, but the biggest risk factor is venous stasis. So heart failure patients, specifically right side heart failure patients, or certain medications like birth control can make you more at risk for DVT development. Also, sitting for long periods and not moving. Venous flow has valves in it and skeletal muscle pumps from A&P. The movement of our skeletal muscles compressing the veins helps them flow back to the heart. So if I'm not moving, I'm essentially having sluggish venous stasis. And so a long car ride, long flight ride, combination of health history equals possible DVT development. So venous thromboembolism management, VTE management. Again, we can do blood thinners, heparin. We can do clot buster drugs called thrombolytics, but those have to be monitored. We could do open the vein up and remove the clot. What's called a IVC, vena cava filter. IVC is an inferior vena cava filter. They place a filter in the inferior vena cava because that's where most clots come from, the legs, so the inferior side of the vena cava. And they'll place this filter in that's designed to catch clots and keep them from going to the heart, keep them from getting to the lungs to cause a PE, that sort of stuff. But they have been known to associate other risk factors too. So an IVC filter is not always the first choice. So for chronic venous insufficiency, again, the other name for this is basically there's PAD for the artery and PVD, peripheral vascular disease, as in just any kind of vasculature, but they're usually talking about chronic venous disease. This would be obstructions or disorders of the veins. So venous blood pressure is too high, veins get distended, venous stasis, that sort of stuff. Again, our veins are usually going back up from the feet, especially, and those are always fighting gravity. And so they have the biggest risk for development of this. And you can see that the varicose veins, skin changes, edema, ulcer development, that's all pretty common with that. Chronic venous insufficiency management. This is neat to know. What should we do for this patient? Well, we can elevate their legs to kind of help prevent swelling and get venous return. Avoid really constrictive clothing, compression stockings. Compression stockings apply equal pressure to the whole calf and leg to help with venous return. Make sure they're doing active, like they're actually walking around. Report signs of skin changes or ulcer development, that sort of stuff. Varicose veins are just dilated, kind of tumultuous veins that twist on themselves, and they become basically varicose veins are related to valves in our veins that are incompetent and not doing what they're supposed to do. They can treat these surgically, but they're usually superficial. They can be deep. Varicose vein management, similar to any other cardiovascular intervention, they can go and strip the vein. They can, if it's a big vein that has that problem, they can bypass around it. Person like this is encouraged walking, compression stockings, that sort of stuff. So one thing to know is there are different types of ulcers, so skin breakdown that develop from either venous or arterial blood flow issues. And so you want to kind of highlight these. So leg ulcers can develop basically just cell death due to inadequate oxygen and nutrients to the tissue. But the characteristics, the difference between the ulcers depend on if we're talking about venous or arterial. There are some differences, and you want to, this is neat to know. You want to know the difference to be able to tell if something's venous related or if something's arterial related. The reason why, too, is that if you see these differences, you notice these, you can start helping the patient on the path to like, what should we work up? We need to do Doppler studies for artery flow, or is this all venous related? So do they have heart failure? What's causing their venous stasis? Do they have a job where they're not moving enough? What's going on? So there's a lot of pathways you can pursue if you realize that ulcers are related to venous stasis or if they're related to arterial blood flow problems, peripheral arterial disease. So typically the difference is for venous ulcers, they tend to be more around the ankle or upper leg. And they have a very irregular border. Do you see the kind of this border is very like all over the place, right? There's different variations and tissue healing and that sort of stuff. Those are and they're usually superficial. So they're usually only involving the epidermis and dermis. They don't usually go too deep. They can. We're not talking about pressure ulcers here. That's a different. Pressure ulcers are in the same family, but they're a little bit different for their reasoning developed. These are purely developing from venous flow problems. Arterial ulcers tend to be more around the foot, toes, and heel. So more distal to blood flow, right where the capillaries are. And they usually are always typically circular and very deep. They usually go into subcutaneous tissue and that sort of stuff. And they're associated with very, very severe pain, have necrotic black tissue that we'd call gangrene. So they're much more round, much more likely to be deeper, severe pain, and more distal toes, distal end of the foot. And these are a couple charts, if you want to pause and look, that kind of summarize the differences between venous and arterial ulcers pretty well. This one as well, kind of what's happening there. Usually venous ulcers have edema and weeping of fluid, but yeah, I think it's a need to know kind of the difference. I mean, overall, what's the management? Medications, antibiotic creams, wound care. For venous patients, could be compression socks and compression therapy. We want to restore skin integrity, kind of improve their mobility, adequate nutrition. If you want wounds to heal, you have to have appropriate nutrition, lean, high proteins, good fiber, good whole grains, that sort of stuff. And this is kind of talking about what the symptoms are. I mean, mainly there's going to be pain, but it's arterial, intermittent claudication, sharp pain, where venous is much more cramping, dull, aching. And their pulses should be present with venous insufficiency, although they could be hard to palpate with edema. And with arterial, they could be diminished or could be absent. And there usually is a moderate to severe edema with venous insufficiency problems with minimal with arterial. And then kind of last, cellulitis is kind of tagged into this. Cellulitis can develop from either one of these conditions, but it's most common really just what cellulitis is an infectious agent gets into the skin through edema or through the weakened kind of blood flow, and it's going to cause generalized swelling, redness, and warmth and pain to that area. And we have to manage this with antibiotics. If there's no wound, there's nothing to culture. There's just general antibiotics that are going to treat more common. These are most commonly the bacteria involved in the infection is going to be something that's a normal flora to our skin. So that is summarized at the end of chapter 26. Thank you guys for listening. Catch you guys on the next one.